Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos. And if you're new to us, man, we're really excited to have you here. We're really excited to have you here because we're having some fun conversations with captivating leaders that are painstakingly changing the future of healthcare. And we're very passionate around healthcare innovation, adoption, things around access and leadership. And if it's your first time tuning in, let me just sort of take a quick step back and tell you what we're trying to get done here. So we're focused on bringing stories of innovation within healthcare to life. So the objective is talking to real people that are on the front lines, getting stuff done within our space and giving them the platform to be able to share their stories ultimately with our community and the world. And we've just got an amazing year with some incredible speakers. And if you haven't had the opportunity to check out any of the historical interviews that we've done, make sure that you hit the subscribe button now, wherever you are, so that new interviews come directly to your inbox. And our field is constantly changing. It's fast evolving. It's crucial that we have leaders that envision the future and eagerly anticipate and embrace innovation to address many of the pressing challenges that we're facing today. And our next guest on the show, she is one of these leaders. Today, we are incredibly honored to introduce a leader whose work is shaping the future of healthcare through innovation, education, and an unwavering dedication to community health. Dr. Vidhya Prakash. Dr. Prakash is a distinguished professor of clinical internal medicine and a passionate faculty member specializing in infectious diseases at the Southern Illinois University School of Medicine in Springfield, Illinois. Dr. Prakash also serves as the Associate Dean of Clinical Affairs and Population Health, as well as the Chief Medical Officer for SIU Medicine. So Dr. Prakash is a well-respected voice on statewide health policy, serving as the chair of Health and Healthcare Committee in the Illinois Council on Women and Girls, and the chair of the Illinois Department of Health Diversity in Healthcare Task Force. So her work in these roles has been tremendous. We want to really highlight that and showcase the work that she's doing to advancing diversity, equity, inclusion within our healthcare system, ensuring that all individuals, regardless of their background, have access to high quality care. So we're delighted to be able to dive into Dr. Prakash's journey, her stories, exploring her groundbreaking work in healthcare innovation, and just shaping the future of medical education. So Dr. Prakash, welcome to the show. It's great to have you.
Thank you, Michael. I'm honored to be here. Please call me Vidya.
Okay. So Vidya, let's take a little kind of backdrop. So you're doing quite a few things. Give us a little bit of a flavor of sort of how you got into medicine, what inspired you to want to do this type of work, and then we can kind of dig into some of the work that you're doing today.
Sure. So it's interesting. I grew up in Cincinnati, Ohio. Mine is somewhat of an immigrant story too, Michael. My heritage is Indian, and my parents were married, moved to France, had my brother and me, and we came to the United States when my brother and I were toddlers. So I grew up in Cincinnati. I
Nice.
really thought I was going to be a lawyer, and then I took an anatomy and physiology class, and the rest is history. So I went to medical school in Ohio, went through residency through the military. I was in the United States Air Force, active duty, and
Thank you for your
served.
service.
Yes, yes. Very, very proudly served the country and made a decision to be discharged honorably from the military and came to SIU Medicine in 2014. So I've been at Southern Illinois University School of Medicine for about 10 years, where I've continued to practice infectious diseases. And I took on my current role as Chief Medical Officer and Associate Dean about 2 years ago in 2022. So then the question becomes, well, how did you go from clinician to administrative? Why did you make that leap? And it's interesting. I feel like my leadership story throughout my life has been I've sort of fallen into leadership. Somebody has usually a mentor has tapped me on the shoulder and said, you know what, I think you would be really good for this. And that's what's exactly happened with the CMO role. I had multiple mentors tap me on the shoulder and say, you would be really good for this, especially around health equity. And so here I am. That's my story in a nutshell.
That's fantastic. So when you think about your story, what was sort of an impactful moment in your career that bolstered your commitment towards not only just healthcare innovation and also equity? Like what was that got you so
Yeah,
locked into this?
yeah. I think it starts with my role as a physician, Michael. And it's interesting because when I started my role as CMO, something that I told everybody, all of my bosses, those who would be my bosses, and everybody in leadership was, cracks. I've seen so many of my patients struggle with access, and struggle with the upstream drivers of health, where
Yeah.
whether it's inequitable access to housing, food, walkability of their neighborhoods. Having seen that over and over again with my patients, I realized, wow, I can be in a position where I can actually influence that and impact their stories in a positive way.
Hmm. So when you think about what you're doing at scale, what do you think is the most underrated skill or attribute that a healthcare leader ought to possess?
Listening,
Hmm.
listening. So listening to all of the stories from beginning to end and getting to know our patients and their values and their entire story. You know, when a patient comes into the doctor's office, we pay attention to their vital signs, right? We look at their
Hmm.
temperature, their heart rate, their respiratory rate, their blood pressure, and it ends there, right?
Hmm.
We're there to monitor their blood pressure, their diseases, but we don't get the whole story. So the whole story is, especially for patients who are billed as non-compliant, why are you missing your appointments? And I have patients who say, I can't afford a bus pass. I lost my job. I don't
Hmm.
have transportation. I can't afford gas. I can't afford a bus pass. That's the whole story. It's not that my patient is willfully non-compliant. It's not that my patient doesn't care about their health. It's that they don't have basic resources that we take for granted. We as physicians and clinicians take for granted that our patients are up against that prevent them from fully engaging with the healthcare system. And then the question becomes, is this our lane? It absolutely is, because it impacts their health. So it absolutely is our business to look at all of those upstream drivers of health. How can we help this patient if they're struggling with transportation? How do we get them here? What can we do with our resources to get them here? And it's easy to tell patients you need to lose weight for better health. But if
Right.
I have a patient who's living in a food desert and doesn't feel safe walking in their own neighborhood, there's diet and exercise right there. That's a huge challenge for them. How can we in healthcare help with that? It is our responsibility. It is absolutely our lane.
How do you train your team of clinicians to be better listeners? And then how do you measure the effectiveness of their listening ability?
You model it. It starts by modeling. So your learners are not going to be good listeners if you, as their role model, and the physician in charge of the clinic, don't do it yourself. So
Hmm.
anytime I have a student in clinic, a resident in clinic, I try to model the listening. Even if I'm running behind, I'm still going to get the whole story and I'm going to get to know my patient well. And a common method that we use in clinic is teach back. What did you just hear?
Hmm.
I told you a couple of things. What did you just hear? So that's on the clinical side. But the other piece is ensuring that our patients know that we listened, right? So what I heard from you is you're really struggling to get your bills paid on time because you just lost your job. And I understand that it's going to be hard for you to make it to appointments in the next 6 months because of that. So maybe we can convert some of those to telehealth. And that way you can join me through your iPhone. And that way you don't have to worry about gas. You don't have to worry about transportation. Let's work together so we can we can optimize your health and make sure you attain the best health possible.
You know, as you're mentioning that, it seems as though that you being in administration, but also having one foot in direct patient care, is that by design so that you can continue to keep a pulse on what's happening and then maybe bringing those things up to leadership, you and the team, to see how you can solve them? What's your take on that?
Yeah. So there's a myriad of reasons. One is purely selfish. I love patients. I love being a doctor, right?
Yeah,
So that's
yeah.
first and foremost. I will never give that up. It's why I went to medical school. I love being a doctor. I love treating patients, both in the inpatient setting and in my clinic. But the other piece of it is indeed what you said. How do I know as a leader what's going on on the front line when I'm not on the front line?
Hmm.
I absolutely need to be in the thick of it to really understand what's going on with my patients. And the other piece is for the people that I'm leading, I feel I would lose credibility if I wasn't engaged in patient care in some shape or form.
Mm.
So those are my reasons.
I think they're really good reasons. You know, you mentioned mentorship before and how it played a role in your career. How has your approach to mentorship evolved over the years? And maybe can you share a success story that you find particularly rewarding?
Yeah. So I told you that I had several key mentors who tapped me on the shoulder to be
Yeah.
chief medical officer. And one of those is our Associate Dean of Equity, Diversity, and Inclusion, Dr. Wendy Alameen. So when she heard that the position opened up, she was the one who approached me about it. And I totally dismissed it. I said, ha ha ha. I laughed out loud when she talked about it because I never saw myself in that level of leadership. But she was the one who pushed me. She said, you are deeply committed to health equity. You have proven that over the course of your career with what you've done with our
Hmm.
patients. And I also serve as director of our Alliance for Women in Medicine and Science. So I was committed to closing the gender equity gap, the great gender divide. And I had done a lot of work in that role. So she saw something in me that I didn't see in myself. And initially, I very reluctantly applied. But then, as I learned more about the role and all that I could accomplish, I started getting really excited about it. And that's the power of mentors like Dr. Elamine. That's what they instill in you. They make you reach into the very best part of you to give back to the community ultimately.
Yeah, when you talk about leadership, it's also seeing something in someone that they don't necessarily see in themselves right then and there, and they kind of pull it out of you and they say, "Hey, this is here,
Mhm.
this is in you," and then belief becomes believable, and then you start to kind of
Yeah.
gain that momentum, and ultimately you do the same for others, and it continues to sort of pass on and on and on. And your
Mhm.
commitment to diversity and inclusion is unwavering. What measures do you believe need immediate implementation in order to improve in order to improve equity in healthcare delivery?
I think it all starts with data, Michael. You don't know what you don't know. So
Mm,
I think what we need to standardize across healthcare institutions is what data are you collecting around health equity? I'll give you an example. At our healthcare institution, our chief medical information officer, Dr. Michael Dinda, is doing a lot of work around pulling data from our electronic health record system and looking at, for example, with diabetes control, how are we doing as a practice with
mm.
one of the measures, which is an A1C, which we know is sort of the standard metric of how well we're doing with diabetes control. And then from there, how do we break it down by race, ethnicity, and gender? And if we're seeing gaps, what are the upstream drivers that are contributing to those gaps? We realized up until recently, we weren't collecting data on the upstream drivers. So what he's done is we've started building it in one part of the practice with plans to move it through the rest of the practice. But now we're collecting data around social determinants of health. We're asking
Mm,
about income. We're asking about walkability of the neighborhood. We're asking about housing. We're asking about how fluent, how comfortable they feel with English, because health literacy is a big issue, where if our
mhm,
patients don't understand what we're telling them, that's not going to positively impact their care in any way.
mm.
So now we're collecting that data and we'll have a better idea of what I call the whole story. Up until now, we've only known half the story. So the data is important.
Where does that go? Does that go inside the patient's record? And then how do you make that data actionable?
Yeah, that's a great point. So we're just in phase one, right? The plan is to start building that into a data set where it's almost like we pull it into a dashboard, and then we review the dashboard, look at it collectively, and then by patient to develop plans. I'll tell you something else that our federally qualified health center is doing. They're working with a company called Medical Home Network, which is based in
Hmm.
Chicago. And part of that agreement is using artificial intelligence, AI technology, to build, it's almost like a baseball card for every patient. And on that baseball card, it flags all of the upstream drivers of health that make that patient
Interesting.
particularly vulnerable. And that way, those patients who are higher risk, you link them with the community health worker. And then the community
Mm,
health worker is able to help with things like transportation. If they're struggling with housing, how to help them with housing. If they're struggling with walkability of the neighborhood, how can they work with the city? To help with those things. So you notice we're stretching more and more outside of our offices and
right.
more into the community to work with stakeholders to improve those upstream drivers of health.
Yeah, it sounds like the community workers and the community-based organizations, they are an extension of your practice. They are
Mhm.
partners. And how do you kind of continue to cultivate those relationships? Because you have a finite amount of time. I mean, where does that fall on your prioritization? I mean, when you think about healthcare innovation, most people think about the shiny things, but these little things make huge differences. And is this a is this a priority for the organization across the org?
It absolutely is. Remember, with health equity work, I love how you said we focus on the shiny things, right? We look at the technology, and that's great.
Yeah.
But relationships are essential to this equation. We have to have those relationships. And community health workers are the linchpin in health
Mm.
equity work. We cannot drive health equity without our community health workers. They are our eyes and ears in the community, and they are doing that important work for us. Where the doctor can't be in the community is where the community health worker is. When the doctor doesn't know the whole story, that's where the community health worker bridges those gaps and tells the clinician the entire story and how we can work together to really help the patient achieve their best health. And
Yeah,
as
and
an
often,
organization, we're breaking down silos. We're trying to bring all of our community health workers under one umbrella. So we standardize processes, procedures, and that way we're a united front when it comes to helping our community.
do you find that there's a greater likelihood that a patient will reveal things to a community health worker as opposed to a physician? Why is that?
Absolutely. I think, this sounds strange, but there's a formality to a physician visit, right? Everything from
Yeah.
the white coat to being within the walls of a healthcare institution. I think there's a little bit more formality. And as clinicians, we have an opportunity to start those conversations more meaningfully. Oftentimes, we have our own constraints, right? We have our own pressures. I need to get through this visit in a timely manner. I'm already behind. I have to complete my documentation. And so, clinicians, I don't think are as adept as community health workers to really get the whole story or sit down and really listen. It's an opportunity for us. And so, where we falter in that aspect, the community health worker helps pick up. And then we're
Mm.
working together as one big team to get the whole story and help the patient.
So in essence, they're helping fill out some of some of the stats on that baseball card on each of the
Exactly.
patients. And how often do you and the community health worker team collaborate, communicate? What does that connectivity look like?
Yeah. So right now, our community health workers are doing more on the primary care side. For
Hmm.
me as a clinician, I'm infectious disease. I'm the specialist, right?
Right. Hmm.
But wouldn't it be impactful to fully integrate community health workers across the clinical practice, not just primary care?
Yeah.
Now, that will be a huge cultural and human capital lift, right? But if it's for the best for our patients, isn't that the way we should be moving?
Mhm. Yes,
Yeah.
absolutely. You mentioned around constraints that clinicians face when there's a lot of talk about burnout and moral
Mhm.
injury. What unusual method or methods have you used or deployed or trained the team on to sort of regain inspiration to move and get through that burnout or phase of, I'll just call it fog? What's
Yeah.
worked?
I think talking about it first and foremost,
Hmm.
and in groups of people that you trust, smaller groups, that has been very helpful to talk through the burnout and strategies that other clinicians have used, how we can use them. But as a healthcare institution, we have to develop strategies to reduce burnout. That's
Hmm.
beyond what is it that everyone jokes about? Yoga and, all of those things which are great, but it doesn't ultimately address the source of the burnout, which is all of the pressures that we put on our clinicians, right? So
Right.
something that we're looking into is the possibility of scribes. Can we use AI technology to build in scribes? And that way that reduces the workload of the clinicians. They're typing less. And when you also institute scribes, I feel that as a clinician, you're more able to be a clinician and be
Hmm.
fully engaged with your patient rather than focusing on dictating or typing your note or clicking boxes and getting everything in the electronic health record. I do think that that's one way in which we can help mitigate burnout.
Hmm. You
One
mentioned
of many.
earlier you mentioned earlier about the importance of relationship and the ability to sort of remove obstacles to be able to focus on that. As a healthcare innovator, are there any other, and technology isn't always the answer, we know this, but if there was, is there
Mhm.
any emerging technology that you're really excited about? In addition to, the scribes that you mentioned, the potential of using AI, and AI is sort of a buzzword that's being used now, but how do you and the team sort of
Yeah,
approach emerging technologies and embedding them into the clinical workflow? What's that look like?
yeah, yeah. As a practice, our focus right now is on the AI technology that affords us scribes and putting together the appropriate data to look at social determinants of health. Telehealth is another big one. We're really, really trying to optimize telehealth because it was a game changer during the pandemic. I've lost track of how many patients told me what a godsend telehealth was
Hmm.
because it reduced time from work. They didn't have to stress out about gas and time. So that really was a game changer. Something that has piqued my interest a little bit more that I think we can collaborate with our hospital and local clinical partners on is remote patient monitoring. How much can we use technology to allow patients to monitor from home that obviates the need for hospital admission? Um,
Hmm.
that's something else that is uncharted territory for us that I think is definitely an opportunity to leverage the technology to help our patients.
Yeah, it seems as though there's been a lot of noise within that arena. Some do it better than others, and I couldn't agree more. I mean, to be able to gather passive data on patients where, let's just face it, 99% of their actions that are occurring outside of the four walls of a clinic, you want to get a glimpse as to what's going on, and what better way to do that than through, I'll call it, the virtual care aspect, which also encompasses the telehealth. Just sort of curious when you think about personalized medicine in the future and how it intersects with public health. How do you see that evolving over the course of the next few years?
It's interesting that you mentioned public health, and I hope I'm not going off on a tangent here, but something that we're dealing with in Springfield right now is firearm violence.
Hmm.
We have lost many members of our community due to senseless acts of firearm violence. And you may have heard of the tragic death of Sonia Massey. We're dealing with that right now. And, firearm violence, it is a public health crisis. It is very much a
Hmm.
public health issue. And this is something else that is absolutely our lane. And it's one of those upstream drivers of health. And as a healthcare institution, and I think healthcare in general, we absolutely need to be on the front line of that. And when you look at solutions, Michael, what I don't like about certain solutions that I've seen, not in Springfield, not in our community, but talking at the community rather than
Hmm.
with the community is a
That's right.
big fail. Solutions cannot be done in silos at levels of authority. Community must be engaged in the process. And 90% of the time, I would say 99, even 100% of the time, the community knows what it needs. It knows the problems, it knows what it needs. It needs our help to create the solutions at scale that last. So when you look at what the solutions are for public health issues, firearm violence being just one of them,
Right.
it involves a coordinated approach between healthcare, government, and our community, and all of our community stakeholders to come together and build solutions together.
Hmm.
It must be collaborative. It must be collaborative.
That's innovation. Innovation isn't something that you just, excuse me, tell people and then all of a sudden they do. It
Right.
needs to be collaborative in nature.
Yeah.
How do you gauge, well, like, what are some subtle indicators when you're looking at gauging community healthcare needs?
We just completed a community health needs assessment, a CHNA. And that is driven by our hospitals. They have to do it every couple of years. And this year, our healthcare institution, SIU Medicine, with blessings from our dean, who, by the way, Dr. Jerry Cruz is a huge, huge health equity advocate. We got a big green light from him to really engage full force in the community health needs assessment. And as a part of that, I got to be a part of the focus groups. I got to listen in on a focus group and be a part of a focus group with people impacted by homelessness. And the stories that I heard, heartbreaking, heartbreaking, but I needed to hear it.
Wow.
As a healthcare clinician, I needed to hear those stories. And as a part of the community health needs assessment, we found what the community identified as key priority areas. And those are mental health, that was at the top of the list, homelessness,
Wow.
substance abuse, and care of chronic conditions. And so now, what is our next step? Do we step back and put solutions together as the authority and tell the community this is what you do? No. We continue to engage with the community, work with them on those key areas, and we ask them, what do you think the solutions are? And how do we help make those happen? And our plan is through the Office of the CMO and the Office of Equity, Diversity, and Inclusion, with collaboration with our hospital
Hmm.
partners, we're going to engage with the community on at least a quarterly basis to host town halls where we ask them, how do we bring you in? What are your ideas for solutions? How can we work together to make it happen?
And then what's the timeline for executing on something like that?
It's an ongoing basis, Michael. We don't have okay, in 6 months, we're going to do this. No, whatever small wins we can gain, the time is now.
Yeah. And
We
share them, right?
implement
Share
in
the
real
little
time.
wins.
Yeah,
Yeah.
yeah, share the small wins, and that's what you build on for the bigger projects and the bigger wins down the road. It
I
must be
love
in
that.
real time.
Yeah. Talk about some of the, we mentioned how you're on the task force for the Illinois Department of Public Health, Diversity and Healthcare, and then you're part of AWIMS. Talk about some of that work.
Yeah. The IDPH Diversity and Healthcare Task Force, again, I said this before, you must start with the data. And we realized we didn't really know how we were doing in terms of diversity in healthcare. And we started with the survey of healthcare institutions of higher learning across the state of Illinois. And what we found from that survey was that there's no standardization of equity, diversity, and inclusion initiatives across any of the academic institutions across the
That's
state of
shocking.
Illinois.
That's
And
shocking.
we, yeah, yeah, shocking, but not so shocking,
I
right?
know. I
Because
know.
I don't think that's unique to Illinois. I think that's a national issue, right? And that's part of the reason why we're struggling. So we actually are hosting a summit in October through the Office of Minority Affairs to get those stakeholders together to talk about what is each of us doing well
Hmm.
in terms of strategies around recruiting and retaining a diverse healthcare workforce. Where are we struggling and why are we struggling? And what are some strategies we can build on together or generate together to surmount some of those obstacles that are keeping us from ultimately diversifying the healthcare workforce? We have a fantastic group of diverse healthcare leaders from across the state, and we have fantastic stakeholders who are coming to the summit to have this important discussion. And we importantly will also talk about the Supreme Court of the United States ruling on race conscious admissions
Hmm.
and how we're navigating the recruitment and retention of a diverse healthcare workforce with that recent ruling, the implications, ramifications of that ruling and how it's impacting us and how we're continuing to work together to diversify the healthcare workforce. So that's
Yeah.
the task force. The other piece, I direct the Alliance for Women in Medicine and Science, and our vision is equity and justice for every woman in medicine and science. I will say for AWIMS, probably one of the things I'm most proud of is our promotion and tenure work. Again, that was collaborative. We didn't work in a silo. We worked with multiple stakeholders across the institution. We started with data, and we saw there was a huge divide at the professor level between men and women. Those were the two genders we looked at, where women dropped off a cliff by the professor level. So we took that data, we went to the clinical leaders who were open, they listened, and instituted changes, both to how we're approaching our faculty about promotion and tenure, but also importantly, about the whole process. We streamlined the process considerably and demystified it. And over
Nice.
the last 2 years, we've made history as an institution. The last 2 years, each of those 2 years, 6 women. So 12 women in the last 2 years have been promoted to the rank of full professor, the most in the history of the institution. And that right there is an example where it doesn't take a huge budget. It just takes some concerned individuals, some data, and some meaningful conversation in a collaborative way to impact change.
That's amazing. How do folks follow your work, follow the work of what you're doing with SIU? Just maybe as we round out here, just sort of share with us how people can continue to stay connected with you and the work that you've been doing.
Yeah. I feel what I'm proud of SIU. I'm very proud of SIU because we're developing and we have an established national footprint. We're very involved with the Association of American Medical Colleges. We've got a lot of activity with the American College of Physicians, the American Medical Women's Association, which is fantastic. And between all of our offices in SIU, we're not only active as members, but as speakers too. So we share all of that good
Yeah.
work in all of those venues.
There's been a common theme to this conversation. It's been around proactive collaboration. So looking forward, I'm curious,
Absolutely.
what legacy do you hope to leave in both the healthcare system and the lives of your students and colleagues?
Yeah, I would say I look to the vision of SIU medicine, and our vision is better health for all.
Hmm.
It really is better health for all. So the legacy I want to leave is that our community, every member of our community has better health,
Hmm.
that they achieve the best health. When you take a step back and you look at the definition of health equity, what is that? It's a fair and just opportunity to achieve your best health without barriers brought on by social circumstances. Every patient in our community should be able to say, I have a fair and just opportunity to achieve my best health without any barriers brought on by social circumstances. And that we're improving their health, we're optimizing their health in a collaborative manner. And we're doing that with a diverse healthcare workforce, that the makeup of our workforce mirrors that of the community. And
That's
we're
right.
continuing to work together collaboratively and breaking down silos, right? That's what I envision. That's the dream.
It's a pretty awesome dream. I'm glad you're doing this work. And if those that have tuned in and if you found this conversation to be enlightening, inspiring, please, would you mind sharing it on social media and commenting on what you thought was useful and what you plan on implementing? So, Vidya, it was great to have you on today. It was really exceptional, and I'm looking forward to future conversations.
Michael, thank you so much again. I was so honored to be invited and I have really enjoyed our conversation. Thank you.